Well, greetings everyone, and welcome to the EKG case for the week of June 23rd, 2014. This week's case was sent from Israel by Dr. Moshe Simons, and this is a physician who I've kind of known by email for the past few years. He sent some very, very useful and helpful teaching cases over the course of a few years. I think we've gone through a couple of his in the past. This week's case is one that is relatively rare, and I'm so thankful that he sent this case. It's been really tough to come by. Anyway, let's go ahead and take a look at the case. It's a 21-year-old man that presented and he took care of. It's a 21-year-old, fairly healthy, athletic young man who had presented with several episodes of syncope, and the syncope was occurring not only with exertion but also at rest. Now, that's not what's unusual about this, but we'll get into the diagnosis, which makes this a really important case for all of us. So we've talked before about the differential on the EKG for syncope. We've talked about the fact that these are things that you've always got to look for, even in young people in whom you get EKGs on after they present with syncope. Everyone looks for ischemia, everybody looks for arrhythmias, but remember these other few things that we've talked about. We haven't talked about this, and I kind of crossed it off the list last week because it is fairly rare. Now, this is not by any means a comprehensive list of things that could show up on the EKG after somebody presents with syncope. I mean, people always ask, well, how come PE isn't on the list, or how come subarachnoid hemorrhage isn't on the list? Well, yes, it's true that PE and subarachnoid hemorrhage and a handful of other things can produce EKG abnormalities, but the reason why I like to keep this list in mind and teach this list is because these are things in which your history and physical may give you no other clues. It's just the EKG that tips you off. Well, probably not true with ischemia. Most patients with syncope due to ischemia are going to have some other complaints like chest pain or shortness of breath or something else, but your history and physical oftentimes is not going to pick up evidence of AV blocks. Your history and physical will give you no indication of hypertrophic cardiomyopathy, Brugada, long QT, WPW. These are patients that oftentimes are completely asymptomatic. They've got nothing on history or physical, and all you've got is your EKG. And that's what this list is composed of, and also arrhythmogenic right ventricular dysplasia. And that's why I think this list is really important, and I try to keep it somewhat limited so that people can remember. Anyway, this is the list that we've gone through in the past. So they got a 12-lead EKG, and here's the 12-lead on this 21-year-old, otherwise very healthy young man who's fairly athletic. I'm sure everybody is looking at these T-wave inversions, and can 21-year-old men have cardiac ischemia? Of course. We've gone through full-blown STEMIs in young patients before, so this could be cardiac ischemia. But in a post-syncope patient, there's a couple of things, maybe one other thing you've got to keep in mind when you see the flip T waves in those right precordial leads. Now, we'll go through our list that we just went through a second ago. We're definitely going to keep ischemia in mind. Are there any dysrhythmias or AV blocks? There's really not, so we can cross that off the list. Hypertrophic cardiomyopathy, you look for giant QRS complexes and deep, narrow Q waves, and those are not there. It's still possible to have hypertrophic cardiomyopathy, but the EKG is not pointing you in that direction. There's no right bundle or incomplete right bundle pattern with ST segment elevation of V1 or V2, so let's cross Brugada off the list. The QT is normal, the PR is normal, so we'll cross those two off the list. Hopefully you would agree the PR is normal, the QT is normal, so we can get rid of those from our list. And so there's one other thing that I want you to keep in mind, and that's the diagnosis that we're going to deal with this week, arrhythmogenic right ventricular dysplasia. When you're looking at a post-syncope case and you're thinking about ischemia because there's flipped T waves in the right precordial leads, I want you to also think about arrhythmogenic right ventricular dysplasia. And if you take a good close look at those right precordial leads, in fact, we're going to blow those up, there's something else besides the flipped T waves that you will notice in those leads. In this particular case, it's primarily present in lead V1. In most other cases, you'll see it in V2 and V3 also, and that's a little blip, to use the technical term, a little blip that comes right after the QRS complex. With a little imagination, maybe you can imagine a little bit of a blip right there. There's not much in V3, but clearly in V1, you've got a little blip, and that little blip is referred to as the epsilon wave, which is oftentimes, I don't know if it's pathognomonic, but it's very highly specific and nearly diagnostic for arrhythmogenic right ventricular dysplasia when combined with those flip T waves in those same leads. So V1, V2, and V3 epsilon waves, flip T waves. And so that's what we're going to talk about. Arrhythmogenic right ventricular dysplasia, also sometimes referred to as arrhythmogenic right ventricular cardiomyopathy. This is a fairly uncommon diagnosis. I think since I first heard about this, maybe 12 years ago, I've been looking and looking for cases of this, and I think I've come across only 2 cases. One of them signed out AMA, damn it, and so I never got a definite diagnosis, and the other ended up being diagnosed as an outpatient. There's probably some cases that I've missed because the EKG, and this is an important point, the EKG abnormalities that we're going to talk about, according to some articles I've read, only show up in about 1/3 of cases. So this is a fairly uncommon disease with an EKG abnormality that is relatively uncommon also. But maybe once, maybe twice in your career, if you see it, those are young people whose lives are saved because you will know about this. All right, so it's relatively uncommon. Most reports say it's in the order of about 1 in 5 to 10,000 patients in the general population. Some reports say 1 in 1,000, but most of the articles I've read say it's closer to 1 in 10,000. However, there are certain populations or certain regions around the world where it is much more common. It's 40 times more common in Italy than in the United States. 40 out of 10,000 patients, and for that reason it's considered the most common cause of sudden cardiac death in young people, and it's particularly common in young athletes. So a lot of people in Italy will do routine screening of athletes before they get involved in sports activities. Somebody recently emailed me and from Canada and said that actually in Newfoundland, he lives in Newfoundland, and said that it's relatively common there as well. And I hadn't heard of that before. But the bottom line here is that it may not be that common, but if your patient speaks Italian or your patient speaks Newfoundlandish, then maybe you ought to really raise your level of suspicion for this particular condition in your post-syncope patients, especially those young males. So keep a lookout. And I suppose in Newfoundland and certainly in Italy, many of the acute care physicians already know about this. But for the rest of us, we're going to go through some of the information here. So it has an autosomal, there's a familial inheritance type of component to this. Is autosomal dominant. With variable penetrance. I have no idea what that means anymore. I used to know what that means, but I think all it really means is that it's inherited, but not everybody gets it. Only about 50% of patients who have a family history of it will end up inheriting the gene. So not everybody with the family history has it. Not everybody who has it will necessarily know that there's a family history. So although there is a genetic component to it, it's not perfect in your history. It is more common in men than in women. Enough genetics. Let's get rid of the genetics from our minds once again. All right, what about the pathogenesis? I hate pathogenesis, but I'm only going to provide one slide about this. What is going on with arrhythmogenic right ventricular dysplasia? Well, there's progressive replacement of the right ventricular myocardium by fibrofatty tissue. That's a really highfalutin way of saying that there's fat in the myocardium. Now, this is not specific. What they have found is that patients that are obese can sometimes have this, and there's a couple of other conditions that can have this same type of fibrofatty tissue replacement. But there's a couple of other things that these patients develop. Because of the fatty infiltration, these patients will develop some problems with their electrical conduction system and EKG changes that we'll talk about. And it's also important to know that even though it's called right ventricular cardiomyopathy or right ventricular dysplasia, some reports say that 50%, maybe more, involve the left ventricle. So some people have suggested that it should be called arrhythmogenic cardiomyopathy or arrhythmogenic ventricular dysplasia instead of focusing on right ventricular dysplasia. And for those nerds that are out there and you really want to know what part of the left ventricle is involved, is the posterolateral subendocardium. I suppose the cardiologists out there ought to know about that. For the emergency physicians that really have an interest in knowing about this, well, you probably need to get a life. All right, so just remember, it's not always just the right ventricle. It can be left ventricle also. All right, what are the clinical characteristics? Typically, these patients will have ventricular arrhythmias. VTAC. If the patient's VTAC degenerates into VFib, That's called sudden death. They die. If the patient is lucky and the VTAC is spontaneously aborts, it stops, or the patient gets a quick shock from somebody, then the patient wakes up, and that's called syncope. Or if the patient falls to the ground with VTAC, they're unconscious, and it lasts for a few seconds, and then they wake up, that's called syncope. So we've said this before. Sometimes syncope and sudden death are the same disease along a spectrum. It just matters how lucky that person is. All right. We mentioned already that it somehow, for some reason, tends to be reported more commonly in athletes. I don't know if there's anything about exercise that makes this more common. It's possible. On the other hand, it's also possible that athletes tend to get reported more often. They make the newspapers and they make the press more often because it's a very dramatic event when an athlete, a young high school or college athlete, drops dead on the soccer field or football field or basketball court, and it gets a lot more attention. So it's possible that athletes are at higher risk. It's also possible simply that athletes get reported more often. This usually manifests after the age of 12 to 14, so post-pubertal kids, males more often. It has been reported all the way up into the 60s and 70s, but it is much more common in adolescents and young adults. And many of these patients will have a family history of somebody in the family, mom, dad, brother, sister, aunt, uncle, somebody dying, sudden death, under the age of 35. All right, so always ask about that family history. And if you hear about the family history, this is one of the things that you've got to worry about. What do you look for in diagnosis? We'll talk about the EKG. I mentioned already the EKG abnormalities are present in less than a third, according to some reports, so it's not perfect. But if you see these things, you've got to worry. Echo can give you some indications. MRI seems to be the most common type of diagnostic modality. Myocardial MRI, cardiac MRI, can look and find that fatty infiltration. There's, I'm sure, a particular type of MRI. I don't know what it is. You'd have to look it up and touch base with your electrophysiologist before you order the MRI so that you get the right type of study. Multi-detector CT can give you some information as well. And the definitive diagnosis is probably going to be that biopsy, the endomyocardial biopsy. Gosh, it's been at least a couple weeks since I did one of those in the emergency department. So I'd recommend that you just get your electrophysiologist on board. And again, in my experience, anecdotally, I think MRI tends to be the most common initial diagnostic modality, but that may vary depending on what you have access to. Okay, EKG. The money leads, the leads that you've got to focus on are leads V1, V2, V3. And what you're going to find is T-wave inversions and those very characteristic epsilon waves. Another subtle abnormality, maybe some slight prolongation of the QRS. I'll show you a couple examples of this. And these patients have a tendency to develop ventricular tachycardia or a lot of PVCs. And the morphology of the VTAC or PVCs is the left bundle branch block morphology type of PVCs. And I'll show you what that, or I'll tell you right now, in lead V1, this left bundle type means that the QRS complexes point down, okay? If they point up, that's referred to as the right bundle type of morphology, but this is what you're going to be looking for. All right, so let's take a look at the case that Moshe had sent us. T-wave inversions, V1, V2, V3, slight widening of the QRS, and in V1 in this case, the very characteristic epsilon wave, not much in V2 or V3. Here's a better example. This is, I got off the internet. This is from an online article that was published by a couple of cardiologists, Diaz and also Brugada. This is Josep Brugada. This is published online again in, it was an online journal for the European Society of Cardiology in 2008. And this is a wonderful example that shows everything that you want to look for. You've got flipped T waves, V1, V2, V3. You've got your epsilon waves, V1, V2, V3, more prominent in V1, like usual, and some slight widening of the QRS. And if these patients develop PVCs or VTAC, this, from Wikipedia, this is what you're going to look for. It's the left bundle type of VTAC. That simply means that the QRS complexes point south, point down. And that typically is the type of VTAC that these patients will develop, and hopefully they will wake up from this and not have sudden death. Now, how do you manage these patients? Well, I would say just make it very simple. Get on the phone and talk to electrophysiology. The electrophysiologists live for stuff like this. They live for Brugada. They live for this diagnosis also. They will love hearing about this and talking to you about it. And the general cardiologists seem to know quite a bit about this also. But if you have a chance, talk to the electrophysiology. What they're going to do is they'll do some EP tests on him. If the patient has active dysrhythmias in front of you, you're going to shock them if they're unstable. If they're stable, you can use beta blockers or things like amiodarone or sotalol, class 3 antiarrhythmics. And if the electrophysiologists get a hold of them, they are probably going to end up putting an ICD, an internal cardioverter defibrillator, in these patients if the patient has had a recent cardiac arrest and survived, or has been having syncopal episodes or any unstable episodes of VTAC. They get ICDs. It's debatable about whether prophylactic ICDs should be placed. It's going to depend on your electrophysiologist. Make it simple. If this is all you remember, send them to the electrophysiologist. You'll probably be fine. So when you see that EKG abnormality, get on the phone and get an electrophysiologist involved. And that stuff is what they're going to do. So quick take-home points. Remember, when you get an EKG on somebody who comes in after they had syncope, everybody looks for ischemia. Everybody looks for arrhythmias and AV blocks. Yeah, that's the average people out there. They remember that. But if you're going to be a star with electrocardiography, these are the things you've also got to get in the habit of looking for. Hypertrophic cardiomyopathy, Brugada, long QT, WPW, and if you're a superstar, you're going to remember the arrhythmogenic right ventricular dysplasia. Remember, if you make a diagnosis of any of these, you just saved a life. Most people will make these diagnoses, but these are the ones that you've got to remember that go a step beyond the basics. If you pick up any of these, you just saved a life. And remember what you did. You took a piece of paper and ink and you saved a life. What could possibly be better than saving the life of a young person who comes in completely asymptomatic and ends up having a great life after that because you made a quick diagnosis? And that's what we live for in emergency medicine and pretty much any field of medicine. I think that's what we all went to medicine for in the first place. So, quick take-home points about arrhythmogenic right ventricular dysplasia. What are the things that should heighten your concern for this diagnosis? Young patients, especially males who come in after syncope, pay special attention to that 12-lead EKG. In leads V1, V2, V3, when you see flip T waves and you also see those epsilon waves, get on the phone with electrophysiologists, maybe order that cardiac MRI. These patients have a propensity to develop the left bundle branch block morphology type of ventricular tachycardia. In V1, they have QRS complexes that point downwards, or they may have PVCs that look like, a lot of PVCs that look like that. And make sure to always ask about any family history of early sudden death. Okay? Now, if you want to reference, there's a handful of references out there. This is probably the best reference that I've come across in the past few years. This was published in Lancet in 2009, and the title of the article, Arrhythmogenic Right Ventricular Cardiomyopathy by Basso. It's a very nice review of the pathophysiology, clinical stuff, and the management and everything else that you would want to know about this. So I hope that was helpful. And, this is one more thing. It's not that common, but it's one more thing that I think you've got to get in the habit of looking for on the 12 lead in those young people that come in after syncope. You'll save a life. What could be better? So I hope that was helpful, and I look forward to talking to all of you next week. Bye for now.